hypertension, and a coronary artery disease with an recent PTCA to LAD 3 months back. He was put on dual antiplatelets with clopidogrel and ecosprin. He was wheeled into a ER with complaints of headache and history of seizures since a day, and on arrival he was in altered sensorium. On examination, he was drowsy, arousable, but obeying simple commands. His GCS was 15/15 with no neurological deficits, and the rest of the vitals and systemic examination was normal. Based on his clinical examination, we wheeled into a neuroimaging. Showed CT brain showed acute SDH with a good midline shift of around 10 mm. The rest of the investigations were normal with PTINR normal and a platelet of 1.5 lakh, and ECG showed all Q waves in the anterior leads, and echo was showing a regional wall motion abnormalities in LAD with the EF of around 44% with mild degenerative valve disease. Based on his initial findings and the examination, the cardiology opinion also was taken based on his recent CAD status, and multidisciplinary team counseling was done, and actually the patient was planned for a emergency right frontotemporoparietal craniotomy, the evacuation of SDH. Seeing this patient are multiple questions ponder. This is a case in front of you in the ER. These are the few questions which ponder in your mind, open for discussion. How do you assess the platelet quality in these patients already on antiplatelets? The normal labs seem normal, BTCT normal, PTINR normal, platelets count is absolutely fine, but still we are cautious when we are treating these patients for elective or an emergency surgery. Now, how do we assess the patient platelet quality in these patients? To the panelists, sir.
Thromboelastogram.
Yeah. Nowadays, with the multiple point of care platelet assays available, widespread use of thromboelastography, ROTEM, sonoclot, these are the few things which are widely used. They help you guide through the requirement of blood and blood components, so that we cautiously use. Next, what is the role of blood components when posted for emergency procedures? When such patients are being posted for the emergency procedures, how do we balance the role of giving the blood and the blood components?
Since this patient will be on dual antiplatelets,
Yeah, sir.
It is more of the qualitative problem than the quantitative problem here.
Yeah, correct, sir.
So, as madam said, we'll try to assess the platelet dysfunction from the TEG.
Yeah.
If required, we'll keep SDPs ready,
Yeah.
single donor platelets ready,
Yeah, good.
and then we'll optimize the patient.
Yeah.
According to the time constraints.
Yeah.
And then if if once 1 or 2 packets of SDPs are transfused, we can assure that quality of anticoagulation will be maintained.
Yeah. The role of transfusing blood components prior to the procedure is still questionable, sir.
Questionable.
Yeah. Yes. The moment the surgeon opens up the dura, or in and around that time, will be probably a better time to transfuse because
once the
we have to focus on the
clot
cardiac
is evacuated, that would be an ideal situation.
Correct, sir. Because we need to focus on the cardiac part also, because we don't want the cardiac to be in trouble. So we need to be cautious on that part. And what are the my next question to ponder is, how do we prevent the perioperative bleeding? We don't want too many mishaps, too many fluctuations happening in your patient. There are certain measures which we take to prevent perioperative bleeding from the surgical, from the surgeon side, from our side. What are the few things which we take into consideration to prevent the transfusion of blood and blood components? Too much excessive transfusion is also harmful for the cardiac part, for the cardiac side. How do we prevent? From the surgical side, we ask for a better microsurgical hemostasis. We ask the surgeon to not to ponder around the dural sinuses, so that don't trigger much of the bleeding from surgical part, and hemostatic agents, use of those agents in and around the clot area. These are the few things which we tell from the surgical side. From our side, we maintain normal pH. We have to maintain.
We should try to maintain good oxygenation.
Yeah, yes.
Maintain the hemodynamics.
Yeah.
Maintain the volume status.
Yes.
And keep an eye on the mean arterial pressures.
Yeah.
And avoid things which will imbalance the oxygen supply demand of the heart.
Yeah, acidosis, no acidosis, calcium level should be normal. Okay, no much use, excessive use of crystalloids. You use more of crystalloids in your case, you're causing damage to the heart, and also on the coagulation system, causing a reduction in your quality, circulating platelets are reduced. You are again causing excessive bleeding to your patient. So cautious use of crystalloids, and obviously cautious use of blood and blood components in your case. This is kind of a double-edged sword which you need to balance between the risk of excessive bleeding, at the same time risk of your stent thrombus. So you need to be more cautious. Next is a very important question. You take up the case for surgery, procedure is done. When do you restart your antiplatelets? Because your heart, your LAD stent has been placed just 3 months before. So when do you restart in your post-operative period? When do you restart antiplatelets?
First of all, we can continue the use of ecosprin.
Yeah.
Aspirin can be continued.
Yeah.
We can withhold only clopidogrel.
Okay.
And immediately after 12 to say 18 hours, get a scan done.
Okay.
From neuro side.
Yeah.
If reasonable midline shift is reversed and there is minimal bleeding, we can take a help of a cardiology team and restart it in less than 24 hours.
Yeah. Okay. Yeah. Usually within the first 24 hours, we need to restart ecosprin. If at all, if we have given a break, then within the next 48 to 72 hours, we need to start up the next agent. If there is any bleeding or anything, we need to add on with tirofiban infusion, so that we avoid the stent thrombosis part with a cautious monitoring of ECG and echo. Now next, let's move on to what we did in our case. These are the few things up for discussion. What we did in our case is, with good pre-op counseling, and we made ready 2 unit of Paxils and 2 unit of SDP. We secured wide bore IV cannulas, and arterial line was secured for invasive blood pressure monitoring. We proceeded with general anesthesia with the cautious crystalloid usage, and intraoperatively, once the dura was open, we transfused SDP, and Paxils also was transfused, and approximately the blood loss during the procedure was approximately 500 to 750 ml, including the clot. A subleal drain was placed, and the rest of the procedure was uneventful. Till now we were in the smooth part of the curve. Okay, so we pre-op GCS was good, so we decided to extubate the patient on table. Post extubation, his GCS was 15/15, no neurological deficit, so we shifted the patient to MICU, continued the routine neurotropic agents, antiepileptics, antibiotics with pain management, and GCS was monitored throughout the night. Next comes the twist in the story. GCS over 8 to 10 hours. After 8 to 10 hours, GCS dropped. GCS dropped to 8. Slowly GCS dropped. So the next thing was, we wheeled the patient to the CT. CT was showing reaccumulation of SDH with mass shift, with midline shift. So we immediately secured the airway, put him on mechanical vent. We counseled the attenders for an emergency, redo craniotomy and evacuation of SDH. But somehow the attenders were not willing due to multiple issues concerning the patient. So they opted for a conservative line of treatment. So we, after all the undue risk explained, we started with the conservative line of treatment. We transfused one SDP, Paxils were transfused, inotropic support was started, and patient vitals were maintained stably the day. We post-operative day 2 with stable vitals. We got a repeat CT done on mechanical ventilator support only. A little reduction in the SDH size was noted, and upon cardiologist advice, the dual antiplatelets were started on POD2, and patient slowly was recovering, shifted over to TPs, and by POD3, the SDH slightly reduced, much better. Patient was still on dual antiplatelets. GCS was good, E4 VTM5, and the next day by POD5 the patient was extubated with better GCS, but little E4 VTM6, but the limb power on the left side was around 4 by 5, a little loss of his power, but otherwise he was pretty good. The drain removal was done by POD4, and she was shifted to room by POD10, and the suture removal was done by postoperative day 12. By postoperative day 15, he was discharged with dual antiplatelets and statins on advice with a GCS of 15/15, but with 4 by 5 power on loss left hemiparesis on the left side. The rest of the wound was healthy. What we did better in this case is we were very cautious with the fluid and the blood and blood components management. We didn't aggressively treat it, and throughout the course, regular cardiologist monitoring, ECG and the troponins were regularly monitored throughout. There was no issues from the cardiac side. So there was not much issues. Only issue we faced was the SDH rebleed immediately in the POD1. And what other thing we could have added up in the management of this case was thromboelastogram would have guided us more in the management of blood and blood components. We went a little blindly into the whole process of transfusion, but otherwise if TEG was available, it would have aided it, and we would have probably avoided the even 1 or 2 components of transfusion. But that was the one thing we were in this thing. Otherwise, everything went on smoothly. Thus, when you're managing such patients, for a better outcome, we need to always balance a life-threatening intracranial bleed against the risk of acute stent thrombus. So we need to be more cautious when you're balancing, and we need to balance and then treat your case.
If at all we have an option of giving any advice to the neurosurgical team,
yes, sir.
Better not to put close the skull bone flap, so
we
that
closed it back.
we can anticipate such type of problems in the post-operative period.
Yeah, that is one more
that
added
would
thing, sir.
Definitely been bit helpful.
Yeah, it will be helpful for sure.
Yes, definitely that would be helpful. But in this scenario, a rebleed chance and another craniotomy, so we have taken an option. They have taken an option mostly because antiplatelets needs to be started 24 hours. So a repeat scan within 6 hours would be much helpful. The main thing here is any progression in the bleed within 24 hours with serial scans. If at all there is no progression or any new bleed or no progression, then we can start the antiplatelets in the first 24 hours, after 24 hours. So a repeat scan is ideal and must. And in this scenario, taking the patient's general condition and also the coronary status, an option was taken to place the bone flap. That means that we didn't go for any craniectomy there. So craniotomy and replacement of the bone flap was done at that same sitting. The only reason being not to subject the patient to another surgery and take the risk again, because the brain was fine and there was no surfacing. The only thing is a rebleed here. Yeah, definitely removing the bone flap would be ideal.
If things goes bad, we'll think like this. If things are all right, we think in another way.
That's there.
Thank you, Dr. Sweta.
Thank you.